What we would just like to inform you of, because we know of the public interest that we had of our first case, was that about a month ago, and I'll give a little bit of details later, we did a second penile transplant, and I'll give you a little bit of details on that. And so far, I think it's sufficient to say on this slide that it's going well, and the patient's doing well as well. So I think firstly, we should just say a few thank yous, and forgive me for not putting it in here, but I do want to thank the media as well in relation to the last case we did. I think the media handled the case very sensitively and very well, in particular our local media, and thank you for that, and I'm sure we can expect the same for this case. So then the second first, the donor family. It's a massive thing to donate someone's genitalia or to be responsible for that, and for a family to be willing to do this really shows care and empathy with the project we have. And this family also were willing to donate virtually all organs that we could use. So that a big thank you to the donor family. And then this project, which I could not get funding for initially, was funded by the Western Cape Health for these two cases. And this funding may have run out, and it really is a project in the realm of the research arena. We do not have funding for this amount of money. We are extremely thankful for Dr. Erasmus and Dr. Beth Engelbrecht to allow this as a clinical incident, of course very well monitored, very detailed cost analysis were done on the first one, and we were asked to reduce the cost, which we already have done. And I think we've reduced the cost to the degree that we can maybe present to government a plan how to move forward on this very, very sensitive issue. And then also a big thank you to our transplant team, who I will just, the ones in front, just play a little bit more about than Professor Blitz kindly said. If I may start at the end, Dr. Bertha Bailey, Sister Bertha Bailey, she really is the mother of the young men who suffers very badly, and they are at an absolute state of horror when they often see us, and the amount of hope that this project created really fits in with the Stellenbosch University Project Hope, that you might be aware of. So this really plays a huge role. And then Dr. Nicola Barsdorf is a brilliant ethicist. As she knows, he's also the head of our ethics committee, but she's a full-on team member with a mandate to make sure that everything goes ethically on this project. Of course, there's lots of ways that a clinician like myself might not be able to do everything ethically, but she's got a mandate to make sure we do that, and we really listen to her. Then Dr. Amir Zarabi is one of the urologists in the team. He's a brilliant microsurgeon as well, particularly known for microsurgery on the vasovasostomy and vasoepiduralostomy level, with working with magnification up to 40 times, which is really huge. So it was nice to have him on the team, with the insight that we have. And then Dr. Zamira Kaiser, he's a really brilliant trauma surgeon. Very fast, he joined our transplant and penile transplant team this year. And she's making a big impact with finesse and surgical skills, and it's also nice to have females in the team, to have a balance in the team. Then Dr. Alexander Zulke is a very essential part of the team. He's our plastic surgeon on the team, and he really has done a large part of the operation with a microscope, with me assisting him. His skills are phenomenal, and we are very thankful to have him on the team. He's a good team player, worked very well with the team, and he's made an enormous difference, as the new head plastic surgeon on our team. Then Professor Rafiq Musa, we've really walked the path since the previous case, and his insights into the immunosuppression is incredible, and even at the scrutiny of international authors and writers and reviewers, we stood up to the previous case in South Africa in a very strong manner, which made me very proud in the way we could. And then also from Professor Blitzko's, Prof Volmink is away, currently our dean, and Professor Blitz standing in. Thank you very much, Julia. I really appreciate it's really worked together. And then just a quick word before a slightly longer word later on the recipient. The recipient is a 40-year-old gentleman who lost his penis in 2000, so close to 17 years ago, after a ritual circumcision went wrong. As he called it, he had to walk a path. He went through very difficult times. He was depressed, he was suicidal, he was admitted with suicide tendencies. He was nearly off the program for that, but he just stuck in. This guy really has got a lot of tenacity, he's very positive, and he's extremely thankful. We had about 12 cases on the waiting list, and we lost, except for the one that we transplanted, we lost the majority due to just they lost hope. Uncontactable, and as we know from interviews, we think a number of them committed suicide. This guy was on the verge of committing suicide, but he hung in there, and today he's very, very happy to have his penis back. Then also the staff in A7, which are our transplant ward, they are really looking well after our recipient. They are a superb bunch of people, and really happy. Then from our own urology staff, my consultants, and the registrars, we have a superb bunch of registrars. They work hard, they work clever, and as a team we are willing to take on any other urology team in the world. So just a little bit more detail on this penile transplantation. We performed this on the 21st of April, sorry for the spelling, it's 2017. The 40-year-old recipient, he was 36 when he joined us. He was about 17 years without a penis, and the surgery took about 9.5 hours, slightly longer than the previous case, which has to do with the way that I was doing the harvesting. We were extremely rushed because our donor patient was becoming hemodynamically unstable, so we had to go in very quickly, and therefore the blood vessels were much smaller than I would have wanted them, making the surgery for Dr. Zilke and myself more difficult to reconnect all the blood vessels up. We took him back to theatre once for a very minor debridement of less than 30 minutes, just a piece of skin that needed debriding or became necrotic, a small piece of skin. There is a significant colour discrepancy between the donor and the recipient, which we'll address with the medical tattoo service at about 6 to 8 months. The tattoo service that we use, you can ask maybe more questions to Dr. Zilke, but if you think of the nipple tattooing of the breast reconstruction, the medical tattooers are really brilliant, and we are very positive that we'll have a near perfect result afterwards. Of course, a penis tattooing is not as easy, because as you think, the skin on the penis is not a homogeneous gradient. It's a slight gradient from light to dark on the penis, and these very slight differences will instruct the tattoo artist to incorporate. And at this stage, the patient is really extremely happy and thankful. We had him evaluated by our psychologist. He did not go through the traditional, or what we have on our protocol, the pre-assessment with the psychologist, because he was actually admitted as an inpatient in psychiatry where he was admitted, so that formed part of his pre-operative assessment. And there they learned him to use different methods of coping. In other words, not to use alcohol and get a support structure. So he's actually different from some of the other people on my waiting list. He's got people that support him, friends that come and visit him in the hospital that's aware of his condition. This is just a picture on the microscope of me and Dr. Zilke, of me assisting Dr. Zilke here, where we get the blood vessels out for for anastomosis on the microscope. This is on the bench preparing the penis. At the back you can see one of our fellows assisting there. And this is actually what it looks like on the microscope screen. There's actually a blood vessel underneath where we're working. So it is about 9 times magnification, and the blood vessels are being sorted out. I'm just going to quickly say something on the graphs. Dr. Zilke will say a little bit more detail. But there's, of course, all these blood vessels and nerves that have to be reconnected. And I think what made this, if I may call it that, the Stellenbosch penises work better than the other ones that was done in the world. Of course, in China there was one done that wasn't successful, skin necrosis, and then had to be removed. And then recently in Boston, Massachusetts was one done. So this is probably the 3rd successful one in the world. And there's a rumor that one was done in London, but I couldn't confirm that. So we are the only center with 2 successful ones, which we are very, very proud of. It's very difficult and rare surgery to perform, so we good at that. But I think the the difference with us to the other centres are that we bring in complete new and strong blood supply to the penis. So these arteries that Dr. Zilke will tell you about, we dissect them out from the abdomen and we take them down to the penis. So it's like giving very good blood supply. It's like you have a small car and you actually take the small engine out, you put a big engine in. This is a little bit like this because we're putting much stronger, much bigger arteries onto the penis than before. And then the blood drainage is very, very important in penis. So we didn't use any of those vessels of the patient, but we used a vein in the leg. So all the blood of the penis goes towards the leg. And we believe that makes a big difference in the outcome. So these are the things Dr. Zilke can talk a little bit more about. This is after 9.5 hours of surgery. We were all there, no toilet breaks, so we were all happy for that. It's Dr. Kaiser here next to me. It's Dr. Mantica, an Italian fellow. On the basis of the first penis transplant, we got a lot of good publicity, and we have a lot of fellows. There's one of the fellows that came to join us after that. Then myself and one of my registrars, Dr. Duplessis, Dr. Zarabi there with the loops on. Next to him is another fellow that came to join us, after the first penis transplant, Dr. Brandy Miller and Dr. Zulke, and our scrub sister just looked away for the moment. So this is what I have to say. I'm going to ask Prof Blitz to just announce his message. Yeah, Dr. Baasdorf, Dr. Nicola also. While Dr. Baasdorf is coming up, she has a very sore back, so Nicola, just be very careful here. And she did something to her back. When I started this project in 2009, I, through the luck or whatever, clicked that the mainstay to get success of this project was going to be the ethics, to get the ethics right, and that's why I got Dr. Baasdorf involved, for a very long time. And you can just tell us a little bit about the ethics of penile transplantation, which is really difficult and interesting.
Okay, thank you for the opportunity to present on ethics in this forum. It really has been a privilege and quite an exciting journey to be part of this team. The ethics of penile transplants can be a minefield, and there's a lot to talk about. But what I've tried to do today is just to focus a brief sort of 5-minute talk on 3 of the key issues that our team has been working on, from inception and the planning of the study right through recruitment and to where we are now. And those 3 are firstly trying to minimize therapeutic misconception, and I'll talk a bit about what that is, appropriately mitigating risk, and thirdly respecting our research participants. So therapeutic misconception is something that one worries about in all research projects, not just in a penis transplant, and it refers to when a research participant doesn't fully understand the difference between research and treatment. So it can include the fact that a participant overestimates the clinical benefit that they're going to get out of the procedure, or they underestimate risks of harm. To minimize therapeutic misconception, our team has implemented a really rigorous informed consent process. And informed consent done over a period of time allows individuals to exercise their fundamental right to choose freely whether or not to participate in the research based on a full understanding of all the relevant information. So our participant has been on the waiting list for quite a long time and was counseled over a period of a few years while there, during which we assessed his understanding of the risks, and he really gave a truly informed and voluntary consent to this experimental procedure. The second ethics consideration that I just wanted to touch on is appropriate risk mitigation. So in any study, the risks to research participants must be proportionate to the benefits to those research participants or to future patients that would be receiving a successful treatment. So our team has carefully considered risk mitigation for emotional risk, social risk, psychological risk, and physical risk, including the myriad of potential side effects for long-term immunosuppression. And each participant, participant 1 and 2, were selected based on their lower risk profile. So there may have, and there were, a number of participants that were eligible for scientific reasons, but they were at substantially higher risk of physical and or psychological harm. And so we selected the lower risk candidates. The third point that I wanted to touch on is really respect for research participants. So researchers in all projects, again, are ethically obligated to respect the dignity of participants in an ongoing manner. That means that if one of our participants would like to withdraw from the study at any point, they may. We also have a duty to monitor their welfare throughout the period of the research. And so our participant comes for multiple visits regularly to check on his physical health and has access to a mental health professional to assess his psychological or mental health, and is provided with access to services for those. Also key on this is respecting confidentiality. So we want to respect our participants' confidentiality to minimize risk of harm, for example, stigma, and particularly with such a sensitive issue. And this means we respect our participants' right to choose to whom and what personal information is disclosed, and at this point his identity remains anonymous. So just a quick summary slide. I think health research ethics consultations on a research project like this and others can help. Our research team proactively sought to address all ethical issues right from the beginning through the planning and design and conduct of the study, and consulted closely with ethicists. I've named another two who have also given inputs, and I think this demonstrates dedication and perseverance to getting the ethics right. Thank you.
Colleagues, ladies and gentlemen, thank you very much for the opportunity to talk a little bit about the microsurgery on this transplant. I'm as thrilled as André and a lot of the members of the team about the success of this transplant, as well as the change that it will make in the patient's future life. You can't overemphasize it, but it is that we have to thank and acknowledge each team member's contribution, and without all the people that work on it, it won't be possible to get to this point. Microsurgery is defined as various surgical procedures performed under magnification and with small specialized instruments, permitting very delicate operations. This is achieved by very careful dissection of the structures in the donor organ as well as in the recipient, followed by the anastomosis of the vessels and cooptation of the nerves under the microscope. As with the first transplant, we had problems with the recipient vessels, and the recipient's vessels directly, which were the ones that would usually match the donor vessels that we dissect out. We had to bring in further vessels, as André already mentioned, and we dissect and reroute these regional vessels to bring in and let out the adequate blood supply and flow out. There was also quite a marked caliber discrepancy. We had very small arteries and quite a very large diameter of the donor vein. And we managed to find adequate recipient vessels that can then match these donor vessels. So on the donor penis, we identified and dissected in total 4 donor arteries, 1 large vein that I talked about already, and we always need nerves so that the penis later on is able to, the patient is able to feel sensation in his organ. In the recipient, we identified and dissected 2 recipient local arteries, and then the vessels that I mentioned already, the regional vessels, 2 arteries from the abdomen, and a recipient vein from the leg that we had to isolate on the recipient. Then again, the local nerves on the recipient penis connection site. Here you can see the donor penis with the adequate vessels. There are 2 arteries on the dorsum. Those are the 2 dorsal arteries. Next to it, the nerves, and in the center, the very large vein that we had. Usually you're not able to identify nicely the deep central arteries, but we were able to see them clearly and we marked them. There you can see that we worked on a side table and dissected all these vessels out under the microscope already. After this first step, we went then to the patient. Initially, the patient was not under anesthetic, but once we had all the structures identified, we then moved on and dissected the recipient vessels. So we took those two deep inferior epigastric arteries, which usually supply the abdomen and muscle, and rerouted them under the skin towards the anastomotic site. And from the left leg, we used the great saphenous vein to bring into the operating field. So you can see those crosses there on the dorsum of the recipient penis, which means that they are not available for the anastomosis because they were fibrosed due to the previous infection that the patient had. Here you can see where we used the microscope and those very fine instruments to get into those small vessels and nerves and dissect them out one by one. Those fine instruments are absolutely necessary to anastomose those arteries, which were between 1 millimeter and 2, and we use very fine suture material to get them together, and we go under the microscope to a high magnification to anastomose them nicely to enable good blood flow into the penis as well as blood flow out of the penis. For the vein, which was larger, we used a 4 millimeter coupling device. The nerves as such were also sutured together with, coapted with very fine sutures. That brings me to the end. Thank you very much, and I'm available for questions later.
All right, good afternoon, everybody. Thanks for coming, and thanks for the introduction, Dr. Blitz, Professor Blitz. I'm going to spare you any slides. I won't give you anything too technical. And really, what I do want to do is, in fact, commend and congratulate my surgical colleagues for the incredible work they've actually done. I think that part of the pun, what they are doing is really cutting-edge surgery. I think what they have done has probably never been done before in the world, and I think what we can be proud of is we've done half of the world's penis transplants at this institution. But I think what is really important to remember is that what's being done is essentially an experimental procedure, and the reason for the success of these procedures has been the excellent teamwork that has occurred. As you can see, there's a fantastic team of surgeons together with the nephrologists, but I think the other people that really play a very important part in the success are the nursing and support staff who I think are crucial to the success of a procedure like this. I think the surgeons are, and André is always very, very modest about what they've done. And I think what he's shown you doesn't really capture the essence really well. I think with the surgery itself took 9.5 hours, but they also had to harvest the organs, and following the penis transplants, they still had to do the kidney transplant. So they had a very busy day on that particular day, and I think everything actually worked out. And I think that's testimony to the excellent surgical skills that we have here at Tygerberg Hospital, and I think we're really very proud of what they've done. So you may well ask, where do we fit in this whole business? Well, they do the very exciting part, and we do the rather mundane, but I think very important part of this whole process. And as nephrologists, our role is to make sure that the hard work that our surgical colleagues have put in doesn't go to waste. What happens is that you put a foreign body into a human being. The natural tendency is for the body to reject that, and our responsibility is to make sure that does not happen. And we achieve that by using a cocktail of immunosuppressive drugs, special drugs that dampen the immune system and prevent the body from rejecting the graft. And that's basically what we've done. And we've learned from the previous transplants that we did. It was very successful from the immunological point of view. And we've essentially used a very similar cocktail this time round. The difficult part is that although the surgery has been very successful, the success of the transplant really remains, requires the patient continue the immunosuppression and the drugs that we are using to suppress the immune system essentially lifelong. And that often is quite a challenge. The use of the immunosuppressive agents is not without its complications, and as you can imagine, if you suppress the immune system, the patient does become susceptible to infections and other complications. Those are the kind of things that we, as the people looking after from the medical side, will be looking out for. So I think that's essentially the main thing I do want to say. But I do actually perhaps want to end off by saying that I think it's sad. I think that this should have happened in the first instance, and what we should actually going forward is improve the safety of these kind of circumcisions. And I think we need to talk to the various departments of health in the various provinces to see how we can improve the safety of these procedures, because it really is not fair for young men to suffer these kind of complications. And although I think the penis transplant makes a lot of news, makes a lot of headlines, I think I also perhaps need to add some sort of perspective to this, and that is that by and large, the largest number of patients that are suffering are those with kidney disease, and we desperately need to have do more kidney transplants. Major limitation that we face in this country is a shortage of organ donors, and perhaps through this medium, I actually want to encourage the general population to talk about organ donation and perhaps become organ donors. So I think with those words, I'll sort of say thank you for your attention.
So just on behalf of the Dean, who it was explained was unable to be with us today, I would just like to add our thanks as the faculty to this multidisciplinary team. And although it's an amazing bunch of 7 people sitting in front of you here this afternoon, they actually are just the faces of a much, much bigger team that, as Prof André alluded to, has been working for the last 3-4 years on this 9.5 hours of surgery. So not to forget the other faces behind these faces. And certainly, as Professor Musa alluded to, this certainly makes us as a faculty really proud. Faculties of medicine and health sciences really stand on 3 grounds, or 3 pillars, and our academic standing is based on clinical excellence, which this is certainly a manifestation of, as well as research excellence, which again, this is an absolute epitome of excellent and groundbreaking research. And lastly, the last pillar is teaching, which this has offered many opportunities for teaching, not only the surgery, but also the ethics, the immunosuppression, the dealing with people, and the things that they have to go through. I think that the first transplant was groundbreaking. The second talks to sustainability. And I think that's the other important aspect, that this wasn't just a once-off, but that this is now edging onto being a sustainable procedure, which can be offered with confidence. I think, as with the previous transplant, and as Dr. Barsdorf alluded to, really important to remember the respect and confidentiality that we owe both the donor and his family, as well as the recipient and his friends and family. But I think also, as Prof Musa alluded to, it's really thought-provoking in terms of health in South Africa, both from a preventive point of view, from a use of resources point of view, and from the services that we are able to provide. So I think there are many aspects of this surgical procedure which, although we call it the penile transplant, really makes us think about many, many aspects of healthcare in South Africa.